Welcome, everyone, to the Bob and Brad podcast. I am joined by Rick Olderman, a physical therapist, for today's live event, and we are going to be taking any of your questions you may be having on pain or anything else just physical therapy related. Before we get going too much, Rick, do you want to give a little background about yourself?
Not much. I've just been an orthopedic physical therapist for about going on 30 years now. So I specialize in helping people with chronic problems. So,
Sure.
and I've written a few books.
Just a few and a few programs. Rick, where can people find you at online?
I think the easiest way is just to go to www.rickolderman.com, and there you can find all my stuff.
Rick has also written a book with Bob, so you know how much Bob likes Rick for all our audience who's unfamiliar with him.
Yeah. Bob's a great guy. Great taste in physical therapists.
So if anyone watching live has a question for us, feel free to post it and we will try to answer it the best we can. I do have some questions I pulled from our YouTube videos recently that I will start with until we get some live questions going here. So it can be any body part, any issue you have, except for we're probably not the best with hands, I would say. I know a little bit, but we're not occupational therapists, so it's not our forte. I only know because I've broken my hand a few times.
Yeah. Well, we can touch on it.
Sure.
We may not be the authorities, but we can certainly have something to say.
So the first question I pulled is actually from our last live podcast, which we did on pain management. So it comes from Janine Crochet or something. I'm really bad with names. I apologize. So this person has had many knee surgeries, including a total knee replacement, but pain meds never really worked. They use ice to get some relief. She's very hopeful, but it never works. She's actually going to see a pain specialist before the revision for a frozen knee due to non-removal of extensive scar tissue from previous surgeries. MUA was unsuccessful, as was consistent physio on my part. Previous physio was always successful, usually 12 to 18 month recovery on previous knee surgeries. So I don't know what MUA is. Do you know what that is?
I'm not familiar with that one either. I was going to ask you.
Oh, we can hit on what we know, but I see we did. I've never heard of a frozen knee. I'm assuming it's like a frozen shoulder.
Yeah, sounds like it. Do you have any comments on this one, Mike?
Well, it sounds to me like with all the previous surgeries that they still had a lot of scar tissue that didn't get broken to allow more movement. So I don't know if that's what is causing all their pain still. Like, I don't know what their motion is like or their strength, unfortunately, but I'm guessing it's not great if they're still having pain.
Yeah, there's a lot we don't know in here. So I'm just going to go over some things that I think I'm right off the top of my head, things that maybe to consider. All right. So
Sure.
the knee, of course, is caught between the hip joint and the foot. So when we're walking, the ankle joint needs to be able to bend adequately to absorb stress of walking. We have about 1.2 times our body weight of ground reaction forces acting back up through the limb when we foot strike. And so if the ankle can't bend well, then that force is either thrown down into the fascia on the bottom of the foot, causing plantar fascia, or it's thrown back up to the knee where the surgery has occurred. So my first, question for Janine is, how is your ankle range of motion? Do you have tight calf and soleus muscles? Do you have a flat foot or some other foot issue going on, or old ankle injuries that might be feeding the breakdown of your knee in the first place? Because I think the thing that's interesting about this, Mike, is that she's had several knee injuries, concluding with this total knee replacement. So I feel that there's been a chronic problem with the entire leg, maybe leading into this and feeding this continued knee pain. So that's one thing. And then, of course, then from the hip standpoint, it's very common for females to have femoral anteversion, which means that the thigh bone is rotated inward. So if the thigh bone is rotating inward excessively, that's going to add a lot of rotational torque at the knee joint. Well, what controls the femoral anteversion is the butt muscle in the back, which externally rotates the thigh bone, controlling that and decelerating that internal rotation. So again, I wonder, okay, well, how are her butt muscles going? Does she have a knee track or a hip tracking problem? Does she have an anteverted femur? If so, is it controlled well? What's going on with the foot and ankle? So these are the first considerations I would look at when I look at something that has been so chronically problematic for her. So then, of course, we have several muscle groups that are coming into the knee joint, one being the thigh muscles. And if those are too tight, then that can alter the kneecap tracking of the knee joint. And especially if the lateral musculature of the thigh is too tight, then that will affect the IT band inserts into the top of the tibia here. And so that will alter the rotation of the lower leg bone. So if we look at the knee joint up close, we can see that these two condyles here, all right, are shaped differently. So rotation is built into the knee joint. And if something is amiss, there are either too many forces trying to pull the knee into one type of rotation versus another, this will cause chronic breakdown of the knee. And then the same goes for the calf and soleus muscles coming from the foot and ankle. If they are too tight, then that prevents the knee from traveling forward over the ankle. And so that could also be a source of stress to the knee. And of course, a lot of people ignore the inner thigh muscles, which start here at the inner pelvis, and they insert into the inside part of the knee, and also one of them inserts into the fibula here. And so this is a huge group of muscles that most therapists ignore. And so if these guys are tight here, or there's some problem with them, then those will also cause the knee to be locked into a rotated position. All right. So, those are the major players that I would be focusing on. And then the last one, because the knee rotation is built into the knee joint, at the back of the knee, there's a muscle called the popliteus muscle that most practitioners ignore or don't even know about. And it runs from the inside of the tibia to the outside of the knee joint, and it crosses the knee joint kind of like this. All right. So when we have knee trauma, including surgeries, what happens is that popliteus goes into spasm. Because it goes from the inside of the knee to the outside of the knee, across the back of the knee, it tends to lock the knee into this rotated position again. And so that can cause significant knee pain and lack of range of motion in the knee joint. So if you have a massage therapist, or you can ask your physical therapist to do this, ask them to massage the popliteus muscle. If they're not familiar with it, hopefully they'll look it up first. The muscle belly of the popliteus is more on the medial or inside of the knee, and then it just becomes a tendon on the outside of the knee. So when people are massaging this, it should be from the center of the knee towards the inside of the knee here. All right. I have found that has become my go-to miracle muscle for increasing rapidly knee range of motion and flexibility and decreasing pain. And of course, that only becomes a temporary fix, Mike, because ultimately we have to solve why the popliteus is spasmed in the first place. And so all of these other reasons get to that as well.
So Tink Bell commented that MUA is manipulation under anesthesia. So it's a knee manipulation. Yeah. I was like, oh, makes sense now. Yeah. For those of you who don't know what that is, I just put people under and then bend their knee a bunch so they can't guard against it to try to break up scar tissue. But we did have a couple questions come in on different body parts, but Emily says, talk about muscles in lower back, sciatica nerve, and feet tingling, not from bad veins, she says. So I'm guessing she just has sciatica that's referring down to her feet.
Yeah. So any comments on that, Mike?
Well, if they're having sciatica, they possibly have a side bending problem, is something I know you quite frequently talk about. So do you want to discuss that?
Sure. So I'm assuming it's going to be in one leg, Mike, or did she say plural? I can't.
Emily, if you're still watching, let us know if it's one leg or both legs. She didn't really specify.
Okay. All right. Usually sciatic pain is in one leg. If it's in both legs, then I automatically think anytime we have symptoms in both legs at the same time, a neural symptom, I automatically think it's a disc issue from coming from the spine. A central disc issue will affect both sides of the leg, but most sciatica is a single leg phenomenon.
She
And
says 2. She just commented.
okay, so if it's two legs, then I'm going to guess this, and I don't know whether they've had MRIs or X-rays, but typically this is due to a disc issue. So that doesn't mean that automatically that you have to have surgery for this, but we have to understand what may be irritating the disc then in the spine. And so I would wonder, since she's in contact with us, does she find relief if she's lying on the ground with her knees bent, or does she find more relief when with her legs straight? So the reason that matters is because if she finds relief with her knees bent, then what is that doing to the spine? It's flattening the arch of the spine. So it's changing the pressure on that disc by flattening out the vertebra. And so if that relieves pain or even temporarily, then we have to find the reasons that her spine seems to be too arched. All right. And so this is what I call an extension problem, where the spine is excessively extended or arched that is causing compression of the disc. All right. So there are many reasons for that to happen. It could be standing and walking with locked knees. It could be tight thigh muscles. It could be that you've had a baby previously, and so your spine has been left in this overly arched position that you've never really trained out of before. So there are many causes for that, but understanding the general shape that makes it feel better will inform us as to where you need to go with rehab. So if you're back,
she did mention she had an MRI and it shows L4, L5, and S1 spinal stenosis.
Okay, so
and she's 84 years old for reference.
Oh, okay, got it. And so can she comment, is it mild, moderate, or severe stenosis?
I'll let her comment.
And while she's commenting on that, so stenosis, folks, is when our spinal column goes down through our vertebrae. There's a little hole that it goes through. And what happens is that vertebrae sometimes encroaches on the spinal column. It's a bony encroachment. Stenosis, almost by definition, is an extension problem phenomenon. So most people with stenosis will find that they have significant relief when their knees are bent lying down versus when their legs are straight lying down. And the same goes for standing. If you stand, most people feel more comfortable with stenosis if they're sitting versus standing for the same reason, because standing causes the back to arch more. And if the stenosis is the cause of the sciatic pain, then basically what she needs to do, again, would be to stretch the thigh muscles in the front of her pelvis, which may have gotten tight. And or if she's standing and locking her knees, what that does is it pitches the pelvis forward and causes the back to arch more. So starting to stand without locking the knees, walking around with them slightly bent, and standing with them slightly bent can take a huge amount of pressure off of the stenotic issues happening in the lumbar spine.
She said it is mild pain. Good. Or mild stenosis, and then she said yes. So I'm guessing she means yes, it feels better with flexion than extending. So
yeah. So since it's a mild stenosis, I'm going to guess that maybe a small part of this sciatic pain is due to the stenosis encroachment of the spinal column. But typically, I find, you can help most people with mild to leading up to severe stenosis by changing the biomechanics that we just talked about. Once it becomes severe stenosis, then typically a doctor will recommend shaving out that spinal column to take pressure off the nerve root, but it doesn't sound like she's there. So I think changing the mechanics of how she's using her body will help a lot. So what that also means, Mike, and I'll just kind of tilt my camera down here.
I will quick comment that Kathleen, a different lady, also had spinal stenosis. She has, I think, scoliosis. I think you just misspelt it. But Kathleen, if you're still watching, this stuff pertains to you as well.
Yeah. So, and what scoliosis does, if it's congenital scoliosis, not functional scoliosis, If she has congenital scoliosis, that tends to lock the spine into this arched position, into an extension pattern. So this will help her too. So Emily, if you're getting up from chairs, what most people do, can you see me okay, Mike?
Yep.
Okay. So what most people do when they get up from a chair is they stand up and then they do it like this. That whole last part of standing up is basically just arching your spine. So instead of doing it like that, what you want to think about is squatting up and keeping your spine flatter for longer while you're standing. So that would look something like this. And just that little change it'll set you up for success once you're all the way up, because instead of hinging your back and arching to stand up and automatically encroaching on those discs, you've now flexed your spine and come up in a way that's not pinching the disc, and therefore that should help the sciatic pain too. All right.
Emily just asked if decompression therapy would be beneficial or not too.
Well, it's difficult to answer because we don't know much about her case. There's so many decompression therapy is when they pull the vertebrae apart, right, with a machine, and then that temporarily gives relief to the pinching of the disc. But in my experience, your biomechanics are such a much larger influence on that pinching than a temporary reduction of the decompression. The decompression isn't solving the reason why the disc is getting pinched. It's just solving the disc pinching. And at best, that's a temporary solution for a lot of people.
Yeah, I would say if you're having an extreme bout of pain, it can help temporarily, but it doesn't fix it long term.
Yeah, so that's fine to do as a short-term solution. However, you need to look at your mechanics, tight muscles, are you locking your knees when you're standing and walking, things like that, to really solve this from a longer-term perspective.
Kathleen, if you are still watching with your questions with stenosis and scoliosis, feel free to ask more. But otherwise, I will go on to some of the pre-planned questions until we get more people asking.
Mike, can I comment on scoliosis since we just brought it up here?
Yeah.
So what do I mean by congenital scoliosis versus functional scoliosis? Well, congenital scoliosis involves an S curve of the spine. Typically, people are born with this congenital scoliosis. Medical terms, if someone takes an x-ray of your spine and says, you've got scoliosis, it doesn't say whether it is a functional scoliosis or a congenital scoliosis. So scoliosis just means that the spine is bent laterally in some way. That doesn't mean it's bent laterally up here too. It just means that it's what they see down here in the lumbar area is bent laterally. Most scoliotic curves are functional scoliosis, which means they happen because of how we're using the body. So Mike brought up earlier a side bending problem. The hallmarks of a side bending problem are that a pelvis is elevated on one side, and typically the same side rib cage is depressed on that side. You can see how that is creating a scoliotic curve. So you would go to an X-ray and they would say, oh, you've got scoliosis. But this is a functional pattern. This is not a congenital pattern. And they're not even X-raying what's happening up in the thoracic spine, so you don't really know. So functional scoliosis is easily fixed and has everything to do with how the asymmetries in your body. If you had injuries on one side of your body versus the other, and then you compensate for those injuries, that creates this pattern from a long-term perspective. And then eventually what that pattern does is it pinches discs and nerves and so forth on that side of your spine, causing unilateral back pain or unilateral sciatic pain down the leg. So there's a little sidebar about scoliosis and side bending problems.
We just had a question come in from Facebook from Andrea, since we're talking about back pain. She has a L4, L5 disc bulge, L5, S1 disc bulge, nerve pain to top of the toes. Andrea, just let us know if it's both legs or one. I'm assuming if it's disc bulge, it might be both, but just to specify for us.
And then the same goes for Andrea. We have to understand whether she has an extension problem or a flexion problem and or a side bending problem. A side bending problem can occur together with an extension or a flexion problem.
She said it's just left leg.
Yeah.
Andrea, if you weren't watching earlier when we talked about flexion extension, Rick means lay down on your back. Does it feel better to bend both knees to your chest, or does it feel better just to lay flat on your bed?
With legs straight.
Yeah.
And then the side, because it's a single leg issue, Mike, aren't you automatically thinking this is a side bending problem?
Yeah.
So what I ultimately, to get rid of this, what was her name? Amanda? Is that what?
Andrea.
So ultimately, to get rid of this, Andrea, I would think about what are the old injuries I've had in my body? Do I have chronic ankle sprains? Do I have knee issues? Do I have a hip issue? In 80 to 90% of cases of, let's say, a side bending problem like this, the problem is in the same leg as the side bending problem. In 10 to 20% of the cases, it's happening in the opposite leg. And then what you're doing is offloading that leg and overusing this leg, which is now breaking down, causing the side bending problem.
She just said there's no difference in a prone position, is what she just commented.
Yeah, well, there has to be a difference one way or the other. It either has to feel better with an extension or flexion of the spine. So maybe she hasn't tested long enough. But for sure, regardless of whether you have an extension or flexion problem, you definitely must have a side bending problem.
She said she had chronic falling on her butt roller skating and falling from an attic as a young child and once as an adult. So, but yeah.
Yeah.
Well, work on your roller skating, please.
Yeah,
Don't
more to
fall on
look
your
in
butt.
there, but hopefully, and I'll show you one really easy way, Amanda, right?
Andrea,
I keep getting that mixed up. Sorry. All right. So
That's
one
okay.
really easy way to determine, hey, which leg is this coming from, is just to stand up, Andrea, from a chair with one leg. So you just stand up with one leg and sit down, and then stand up with the other and sit down. So if you do that right now, what you want to pay attention to is that one leg feels much stronger or easier than the other. And so the problem will likely be in the weaker leg, which is why it's weaker. So if that weaker leg is on the same side of where your pain is, then you have a problem, a side bending problem due to some issue in the same leg. If you have a problem if the opposite leg is weaker and your pain is on this side, then this problem in this leg is feeding the problem in your other leg.
She said her right leg is stronger and her pain was in her left side.
Okay, so that means that the problem is in your left leg, likely due to an old ankle issue, knee issue, or hip issue that's feeding the weakness in the left side.
She said she's never roller skating again at 58.
Okay. I wouldn't at 18 either.
She also has some osteopenia post-menopause. She just mentioned that as well. But
yeah, so there's a whole host of problems that can occur in the lower body that could feed this pattern. That then what happens is it feeds this side bending pattern, and then the nerves get pinched because of the side bending pattern that then travel back down the leg again. So when you go to a health practitioner, they'll usually say, oh, you've got a nerve problem, clearly, because you've got the sciatic pain down the leg. But what no one ever seems to really understand is asking the next question. Why do you have a nerve problem on this side? And almost always it's due to a side bending problem on that side that's caused, in your case, Andrea, by an older problem on the same side.
So strengthen and stretch your leg, I guess.
Well, what would be even more helpful is to understand what the problems are. Then you can be more specific about your strengthening and stretching. Yeah.
If you want really more specifics from Rick's program, you can find him at rickolderman.com, where he goes through about everything you need there.
Okay, since you're doing a selfless plug, I'll do a selfless plug.
And he's got a book.
In my new book, Pain Patterns, I go over the 5 or 6 tests that get to the root of these types of problems. And the second half of the book functions as a workbook. So you can tick off where your problems are so you won't forget what they are and which side they are. And then I show you how to fix those. And then all the tests and exercises are found as videos on my website.
She says thank you very much, and she loves
Sure.
this channel, and she has a small amount of scoliosis, but we kind of talked about that earlier too.
Yeah.
Anyone that is watching live currently and has any questions, feel free to ask, and we'll try our best to answer them. Until then, I'm going to go back to some of the pre-planned questions I found from our YouTube channel. The next one is about ankle injuries. So this comes from Ankit Bahalar. I apologize. I'm really bad at guessing these usernames. It's not a normal name. So I'm a little confused with the dates here, but we'll do our best. I had a broken ankle in 21 days. It healed like 85 to 90% now. They're currently 1.5 months out. So I don't get what the 21 days was in reference to, but they're healed 80 to 95%, 1.5 months out, but can't bear weight. Ankle is moving perfectly. X-ray is clear, but I don't know why I can't put full weight on my leg. I'm assuming he is saying it is a guy because I can see the profile picture. I'm assuming he's saying he just can't tolerate weight bearing. I don't see like he's non-weight bearing anywhere.
Yeah. So I'm not clear on why he can't weight bear. I'm assuming it's because of pain, right?
Yeah, that's what it sounds like to me.
Okay. So any comments, Mike?
Well, I'm just curious that his ankle is moving perfectly. How is perfectly in comparison to the other side? Because I don't. It sounds like to me he's probably lacking some motion somewhere, unless it's just not healed all the way, or his fracture, to get displaced a little bit, or did he have surgery? He didn't really specify.
Yeah, I'm suspicious of the 85 to 90% number for ankle mobility. So first of all, the second thing is we don't really know where in the ankle this fracture occurred. There's a lot of places that could influence the reason why it's still painful. One of the things that I'm thinking of, Mike, is that in the outside of the ankle here, we have the fibular head, right, on the outside of the ankle.
Mm-hmm.
All right. And this, you can see the bone is much thinner than the tibia, which is our weight-bearing bone of our lower leg. And we have this outer fibular bone too. I'm wondering if he's had a fibular head fracture. And so what often happens is, this fibular head needs to be able to move in order for the ankle to bend and straighten well. All right. And the movement here is very small. And what I have found often in ankle fractures, chronic ankle sprains, and so forth, is that the fibular head has healed in the wrong position. And so if it's healed too far forward or too far back, if it's moved too far forward or too far back, even like the width of a fingernail, it causes a restriction in the ankle range of motion and pain, because there are ligaments that attach to this fibular head too. So what I wonder is, and there's a simple way to determine whether this is happening. What I do in the clinic is I'll have them stand on that ankle, and then I'll grab the back of the fibular head and I'll pull it forward and ask them to weight bear on it, and I'll see if that feels better. If it doesn't, then I'll push it back with the palm of my hand and see if that feels better. Usually one of those two positions feels better for their ankle pain. And then what I'll do is I'll use my Leukotape P and cover roll stretch tape to tape that fibular head into a better place. And usually that takes care of a lot of pain for people. And we're talking, folks, literally almost no movement at all. It's really the pressure of being pushed forward and back that we're changing, not so much the motion. Likely, if it's been fractured, it's not going to move now. But if we can change the pressure that's exerted on the ankle, that can make a big difference.
We had a question coming from Facebook from Steve. So he's just got 2 comments here. Starts with, orthotics in my shoe, do they help with pain down the back of my legs? How can I tell if my legs are the same size? Had a knee replacement 1 year ago, but then his next comment says he also has pain in his tush. So yes, your feet can affect your pelvis, but this sounds more like it's referring from your back if it's in your tush, not necessarily from your feet up.
Yeah, does he say why he's wearing orthotics?
He did not specify. He's just
Is it
asking.
to solve the leg pain or is it to solve a foot issue? I'm not sure.
Steve, can you just let us know? He's probably still here. So, well, is that a knee replacement? I'm assuming when he says tell my legs are the same size, I'm guessing he means leg length, not like width
Yeah.
and muscle size. So yeah, Steve, just let us know if it's from like a podiatrist you're supposed to wear them or you're just trying. But this sounds like if it's from your tush and going in the back of your leg, that sounds more like sciatica.
Yeah. And what would be really interesting, Steve, is if that sciatica is happening on the same side as your knee surgery. And if you're having foot pain, is it happening on the same side as your foot pain? So this goes back to what we talked about with Andrea.
He just said not wearing now, but he was looking for pain reduction. Oh, he's just seeing if he's not wearing orthotics currently. He's just asking if they would help. It's what it sounds like.
So there's a lot in this question. So Steve's asking about leg length, first of all. I find that leg length differences are very rare. I don't know if do you measure for leg length typically, Mike, when you're working with people?
No, not too often. I mean, most of the time they have like you can tell their pelvis is just shifted. It's not really like a leg length.
Yeah. But I mean, I think you're rare because most people would see that pelvic inequity and see that and say, oh, you've got a leg length problem.
The pain is on the same side as his knee replacement, just so we're aware.
Okay, so it's likely the knee, Steve, is feeding a side bending problem, which is then pinching nerves that is going back down the back of the knee. So ultimately, what we have to do is solve whatever knee issue is happening here. And this goes back to the very, I think, first question we answered, Mike, was I went over all the possible places that could go wrong that affect the knee joint. So the ankle, the hip, and so forth. But ultimately, I'm going to bet that he has this pattern that's pinching a nerve that's going back down the leg and it's being caused by the knee pain. But then, I'm never satisfied with, oh, he's just got knee pain. Like it just appeared out of the wilderness for no reason at all. You've got chronic knee pain for some reason. And usually it has to do with the ankle or the hip or both that's caused that. And the knee is basically caught in the middle of those two issues. And we covered some of those issues before. So is foot orthotics going to help or not? Well, we don't know what the problem is. So it's hard to know whether foot orthotics are going to help or not. But frankly, what I would say is, Steve, just get a pair off the shelf foot orthotics from Walmart or something, rather than spending $1,000 on foot orthotics to figure this out. Just get that cheap pair off the shelf and see if it gives you any smidgen of help. And if it does, then yes, maybe they'll help. But know that the foot orthotic is passively causing a change in the lower body system. There's nothing that's being done to actually fix where the problem is. All it's doing is leveling up the feet for you. So it's not actually it may temporarily remove that pain, but it's not solving why the pain is happening.
Steve, if you're not sure if you have a side bending problem, because some people it's really pronounced and some people it's kind of minute. Rick always says, stand with your shirt off and either have someone take a picture of your back, or if you can see it from a mirror and just see if you have a fold on one side versus the other. If you don't have a fold, we're not saying it's a fold of like body fat or anything, but you can often see in the skin if someone is having a side bending issue.
So here's a picture of them in my book. Let's see, I'll try and hold it up so you can see it. So you can see these people both have a larger crease on the side. I'm doing it in reverse. Let me look at it. So both people have a larger crease on the side of their waist. And if you look closely at this image, you'll see that one pelvis is higher than the other on both of these people. So the crease is happening on the side of the side bending problem. And this is where they were having pain. One was having sciatic pain down their left leg. The other was having left low back pain. So Steve, it sounds like you're having left sciatic pain. So you likely have a crease on the left side if this has been going on for a while. If it's relatively recent, you won't have formed a crease yet.
We have a lengthy question from someone named Tinkbell. This is a person that let us know what the MUA was.
Yeah, thanks, Tinkbell.
Your comment is so long, it cuts off on the bottom. I apologize. So I'll read through what I can of this. You can always comment again, just shorter, just because I'm using a different platform to go live here. It says paralysis of left leg, mid thigh down. Spinal. Oh my gosh, it's a big medical term. Spinal diastematomylia. Birth 60 years ago. Oh, I can't even say that word. That's a long one. I have walked with crutches ever since, and I'm very strong like bull. That's a Brad saying. In my upper body and my right leg, I am quick to move on underarm crutches. Have tried others, but I am quite clumsy with anything other than underarm crutches. Now at this age, wondering what kind of exercises I can do to keep my right leg strong. I do use arm exercycle and lift weights, 3 to 5 pounds of dumbbells, but not much. That's where it kind of cuts off. So it sounds like she wants to figure out how she can keep her arms strong and her good leg strong.
Okay, and did I hear you right, Mike, that she said her left leg is paralyzed?
Paralysis of the left leg, mid thigh down. So sounds like has some hip flexor area.
From the mid thigh down. That sounds like a peripheral nerve injury of some sort. I would think if it was a central issue, it would be more than just a mid thigh.
And she's 60 years old now.
So I'm gonna guess, Tink, that it sounds like you have some function in that left upper thigh, but just not all of it. And so one of the ways, and this is, I mean, I don't know the nature of this injury or the nature or how extensive your weakness is, but I wouldn't give up on strengthening what you do have. And one of the ways I get people to strengthen weakness in their legs without actually having them go to the gym, and I'll tilt this down a little bit more.
She's just saying, yeah, you're correct in what you were saying, and then kind of like spina bodies.
Okay. All right. So what I would say is, don't give up on that left leg, because the more you give up on the left leg, the more that right leg's going to have to carry the load. And then you're more prone to have the right leg break down over time. And then what are you going to be left with? You'll have a left leg that isn't prepared to accept the load again. So one of the ways to naturally strengthen the left leg, if you're standing up from a chair, if you slide the right foot forward slightly in front of the left, just like, I don't know if you can tell, it's about 2 or 3 inches, and you stand up, it's gonna force you to start using more of your left leg. So certainly you can't do a single leg stand on the left, but how much can you do? How far forward can you get that right foot to go and still weight bear on that left leg and keep it neurologically connected to your brain to use when you're standing and sitting? This will naturally strengthen your leg throughout the day whenever you stand up and sit down, and keep it from atrophying more, and may even get help strengthen it more if you start doing things like that. Now, if you're standing at the kitchen sink, then what you want to do is you'll put your left leg forward and bend that knee and shift your weight onto that leg while you're cutting or cooking or washing dishes and things like that, to keep that neurologically connected to your head, and strengthen that leg as much as possible. Not to mention, the more that you can put weight on that left leg while you're doing simple activities, the more it's going to give this right leg a break, and so it won't break down as easily. So I don't know if I answered any of her questions at all, but that's kind of what I'm thinking about for how I'm picturing how Tink is, what she's going through.
Yeah, she said later as a typo. It's kind of like spina bifida, is what she said.
Okay.
We had Lily asked, who was listening during you talking about side bending problem, what exercises can help with side bending?
Yeah, so to answer that, we have to understand why the side bending problem is happening. So there's one exercise that's easy, to do, you can immediately get rid of a side bending problem using this exercise, but it's only a temporary fix because you're not fixing the source of the side bending problem. You're only fixing where it's ending up, which is at your pelvis and waist. And that is, if I have a side bending problem on my right side here, where I have a larger crease and my pelvis is higher, my rib cage is lower. So what these people are typically doing is they're walking something like this. They're just kind of collapsing on that side a little bit. Maybe they're locking the knee more or whatever, but it's causing the pelvis, something is causing the pelvis to elevate while at the same time the rib cage is depressing. So the exercise is real simple. You just simply raise your hand up in the air. And when you stand on that leg, instead of collapsing, keeping the hand up in the air causes that side to remain tall and open. And believe it or not, in 10 or 15 steps, this levels the pelvis and the rib cage immediately. It's amazing. It's a great party trick. And so, well, maybe for physical therapists.
But, look what I could do.
Yeah. Hey, everybody. So anyway, that will immediately solve the side bending problem. But again, it's not solving the reason the side bending problem is happening. And that's what I go into in the Pain Patterns book. That's what the other 5 or 6 tests are in there, is to get to the root of the problem and help you figure out A, which leg it is where the problem is, and then B, which joint or muscle area is causing the problem that's leading to this in the first place. So it can be fairly simple, but we just need to know what the problem is first.
We actually had a good comment here from YouTube. So this guy was on our previous stream asking some questions, Abrar Ali. So he said, "Hi guys, I took your advice and implemented it and have significant progress since our chat. I managed to walk for 30 minutes today pain-free. I couldn't manage 5 minutes previously." Well,
great.
That's good.
Thank you for that. That's awesome.
If anyone else has any questions about pain or wants a follow-up from something they asked earlier and we didn't go into enough detail, just let us know live in the chat. We'll still be here for about another 20 minutes. Other than that, I'll just go back to some of these pre-planned questions.
So Mike, before we go to those pre-questions, I just want to let everyone know a lot of this information sounds completely new and cattywampus probably to anything you've ever heard from your practitioners or found on the internet. And that's because of how we're trained as physical therapists is to isolate a tissue that is at the source of your problem rather than looking at the system that's causing that tissue to be problematic. This is what Mike and I are talking about are systems thinking solutions to chronic problems versus just do a hamstring stretch, or massage your butt and that'll get rid of that pain. That's nice to get rid of the pain, but it's not solving it from a system solution. And that's how our body works, is as a system.
Yes, that's your whole book and philosophy.
Exactly.
And your programs. Anyway, our next question comes from Pam Windsor. So what exercises can you do to get your good leg ready for climbing inside steps? She said, "I broke my right leg in 3 pieces, and now it's difficult to have the strength to lift my leg out on step." I'm guessing lift my leg up on step, I'm guessing she's talking about.
And I thought, I'm assuming she's calling her right leg the good leg, even though it was broken in 3 places. So
right leg,
I'm a little confused by that, getting your good leg ready for climbing.
Wow, maybe she's saying her good leg is her left leg and because she broke her right one. But I'm assuming your left one, just do what you do. Don't do extra because you're just going to make it more sore. You're right. I would work on focusing on strengthening up right leg. I think a good exercise. I don't know, obviously, what your current level is at. It sounds to me if you're having trouble lifting it up and activating it, sounds like some of it's hip flexor, but it could be quads. And I also don't know what bone she broke. Shouldn't really specify.
Yeah, or whether they've knitted together again. Are they does she have a non-union in any of those fractures? So
Yeah.
that's difficult to know. Does she have osteoporosis, osteopenia, things like that? So this gets back to kind of the recommendation for Tink, and naturally strengthening the leg without giving it specific exercises to do. A lot of people don't like to take time to strengthen something that's a problem because it's tedious and they get disheartened. But if you can just change how you're using that lower body system, that will naturally strengthen it for you with taking absolutely no time out of your day at all. And the nice thing is, it's a functional strengthening program rather than isolating muscles that may not translate to function afterwards.
Yeah, so just the staggered kind of sit to stands. Pam, if you're watching this, just rewind a little bit to when we're talking about Tink and strengthening her leg up.
Yeah, and then
is a good option. And then even just doing step ups.
Yeah, here's a small
handrails.
Step. Yeah, and just stepping up and stepping down. And you can start with a low step. You can use a book. You don't even have to have a big step or anything, but just step up. And then when you step down, slowly step down to get that eccentric loading of the leg, and then step up and learn how to lift yourself up. What happens with a lot of people is, let's say she's got that right leg problem, right, Mike? And she wants to strengthen the left leg. What a lot of people do is they push up with the floor one to help the top one. Mm-hmm. And so it robs the top one of the work. So what you got to make sure is that you shift forward and you really use that top one to raise and lower yourself down without using this other one. If you do that, you'll find it's quite difficult to even do a short step with that kind of motion.
And really control the way down too. And even step downs are a good option as well. Because if you're hiking, you got to come down.
Right. So Mike's talking about this motion instead, is stepping down. And what I typically do with that is I do a light heel touch and then go back up to train you how to step down. And then what we also want to pay attention to, you don't want to step down and have this knee completely come in and your body go out to the side. So you want to have that knee tracking over usually that second toe during that step down so that you're in good alignment and your body is staying nice and tall as you do that.
We have another question coming in from Facebook, so I'll read it as you get situated. So this is from Debbie. I have terrible lower back and hip pain, doing all exercises and still a problem. I am perimenopausal, but this chronic pain is literally bringing me down, especially at night. She followed up saying she's been doing clamshells, leg raises, hip rotations as her chiro taught her.
What would you say to that, Mike?
I'm trying to figure out if the pain's coming from your back in your hip or if it's in your hip going to your back. Is a good way to start. And not saying that strengthening your hip flexors and your other hip muscles is a bad thing per se, but if you're still having pain, we have to figure out what's causing it.
Yeah, exactly. So it's very common that hip issues will cause compensations that will play out as back pain. So that's what Mike's talking about. Is this really coming from the hip or is it coming really from the back? And so this goes back to that very first person we talked about, Mike, testing for whether they have an extension problem or a flexion problem as the root cause of their back pain. First of all, is this back pain on one side of the body or is it central? If it's on one side of the body, then they likely also have a side bending problem, right? But if it's more central, then we have to know whether, hey, do you have an extension problem where your back feels more pain when it's more arched? In which case, if you're lying on the floor and your knees are bent, your back should feel a lot better. Or do you have a flexion problem whereby if your legs are straight, your back feels a lot worse because your back is more arched? So that's the first key to knowing what to do. And so then once we understand that, then we simply have to do the exercises that will solve an extension problem or a flexion problem. So it's difficult to know.
She just said, Debbie said it's mostly on her right side. Debbie, is that, I'm guessing, at the same side your hip is hurting too?
And then also, Debbie, you can do that quick test, that flexion extension test. Just lie on your back and let us know, hey, my back feels a lot better when my knees are bent than when they're straight. You might even know that without doing the test. Most people do with chronic back issues do.
She just said that her hip and back are the same side, so it's both on the right side.
So she likely has a right side bending problem where the pelvis is higher and the rib cage is lower, causing more compression on this side. And from a neurological standpoint, the nerve roots are actually in the spine here, right? So they could be feeding down to the hip. But I'm going to guess that she has a right hip problem that's actually causing the side bending problem that then is pinching the nerves in the right side of her back.
She said it helps. I'm guessing, Debbie, you mean bringing your knees to your chest lying down helps? I'm guessing is what she's saying. She didn't specify, but
yeah. So this sounds like likely a hip issue that's feeding the problem. Well, what's the most common hip issue that I typically deal with is something called an anterior femoral glide syndrome, where the thigh bone head is tracking too far forward in the hip socket. So that's where the anterior comes in and the glide, all right? And so why would this be happening? Well, typically because the butt muscle isn't working. The butt muscle attaches to the hip bone. When it's not working well, it then allows this to start shifting forward and creates all sorts of pain in the hip. It can be piriformis-like pain. It can be lateral pain and the bursa. It can be groin pain in the front of the hip, all sorts of things, or it could just be global hip pain. So how do we solve that? Well, first, this is usually rooted in how someone's walking. Typically, what is shutting off the butt muscle is that they are locking their knee straight when they are walking. So what they need to do is learn to walk with their knee slightly bent, which will automatically turn on the glute muscles and then start fixing the tracking problem of the hip joint, which will then reduce the side bending problem and the back pain. The other thing that she could do are butt pumps, which isolate the butt muscle to get it back online.
Do you want to show what a butt pump is quick?
Oh, sure. So I'll get down on the floor.
I can't move very much with this microphone.
All right. So can you see me okay, Mike?
Yeah.
So a butt pump is basically on your elbows and knees. You're just going to lift your leg up. And what I would, for those whose butters are turned off, it's better to turn the knee out just a little bit. And that biases the butt to turn on. And then you just do 20 or 30 pumps using the butt, not pushing with the foot or the quad or arching the back to get it up there. And higher isn't better. That just arches your back and hurts it. Just get it to where it's turning on. Usually an inch or two pump is good. And then switch sides for 2 times. And that will turn on the butt, get it tired, and usually cause, well, in many cases, it immediately reduces that hip pain.
If you're struggle to get on your hands and knees, Debbie, you can kind of do it standing, like leaning against the countertop too, or a wall as well.
So what you would do is, if this is the countertop, you'd be leaning on that, and then you'd lift your leg up like this.
Yep.
So I prefer it on the ground, but if your knees or whatever can't do that, then standing up is good too.
Yeah, I just know reading through our YouTube comments, it's always, I can't get on my hands and knees. I'm like, okay, right. I'm sorry.
And remember, that's on your elbows and knees, not hands.
Oh, yes, on the elbows. Yeah, I learned that slowly after a while. Yeah, so I was going to mention focusing on the glute strengthening is important because Rick told me to do that because I had some hip and low back dysfunction on one of my sides. And I started doing that, and I do some other exercises now, but I really focus on my glute. And I was learning how to test on the Biodex at my other job. So for our listeners, it's this big contraption that you can test different body parts, and you test one side versus the other. And I was just testing my knee. My left side is still weaker than my right side. But interesting enough, after I started doing like changing my walking pattern, focusing on glute strengthening, most of my knee flexion was ranking higher than my knee extension, which is not very common. So I'm very like glute and hamstring dominant, and I used to be all like quads. So it's kind of interesting. But yeah, like my pain doesn't bother me anymore, and I didn't have any surgery or anything. So I found that interesting. Yeah,
it's very common. Once you start seeing a few hundred of these patients, you see it's a very common pattern that almost everyone has fallen into.
Yeah, and it's just, I don't know, it's so odd. I know, like, I don't have gluteal amnesia. I do all this stuff, and then later on, I was like, oh, like my hammies were just really compensating in my quads for that. I mean, I still have to work on. I still have a deficit between left and right, but I need to get that a little bit better than it was.
None of us are perfect, Mike.
Yeah. All right. We still got about 5 minutes. So if anyone watching has more questions, otherwise I'll just kind of pick one more from the pre-planned questions. We'll get into this one. I think we haven't really talked about this yet today. This is from Rob 3ish. I don't know, different username. I sleep on my right side all the time due to a bad left shoulder, but my left lower oblique is really tight and causing tightness in my left lower back and tightness in my left hamstring. I have started getting dry needling along with left oblique, and it's really helping. Well, that's good that the dry needling is helping. I've actually had that done to me. It does feel good and usually lasts for a little while, but oftentimes it doesn't fix the issues because I still had issues after that. But I thought trying to get some sleeping tips so they can sleep on both sides would be a good idea. And I know you got some.
Well, in terms of sleeping tips, the one that I think will help Rob the most, let's say, is to get a pillow. It doesn't have, or a towel, and put it underneath the rib cage on his left side. And what that's going to do, Rob, it's going to unload the left shoulder from weight bearing, and it's going to unload the hip, and it's going to level the spine as well. So you're on this, and so the pillow is just from the armpit to the top of the hip joint here, and so I'm sorry, to the top of the pelvis here, because the shoulder and the pelvis are the widest parts of your body. If you can support those, then your spine isn't going to sag down like a telephone wire between two poles, and it'll take a lot of pressure off the shoulder and the hip. So that's a sleeping position that will likely eliminate the need to sleep on your right side in the first place. But what I really wanted to comment on with this one is that it sounds like Rob has a left side bending problem. So
yeah, and I'm assuming because it could be from his sleeping, but other issues. But yeah, you could talk about that.
Correct. And so what the interesting thing is, Rob, to understand is that the center part of shoulder function is the shoulder blade. And when the shoulder blade is off, that's when we have chronic shoulder issues. Well, the shoulder blade basically rests on the rib cage. So if your rib cage is sitting too low, then your shoulder is going to rest too low. And that's maybe why you have left shoulder chronic pain too, is because of this side bending problem. And so the needling the obliques might help release the side bending problem temporarily, but if you don't solve why you're having a side bending problem, then it's just going to keep coming back again and again, and you have to use pillows to position you in a certain perfect way so that you can sleep. So, I hate to sound like I'm beating a dead horse. This is the side bending episode apparently, but please watch over the rest of the recommendations in this video, because I talk a lot about side bending problems, how to figure out which side the problem is on, because this is likely the root of why you're having left shoulder pain in the first place, and also the oblique issues as well.
So we just got a comment from Facebook, which we've hit on many times today, but this is a different person asking who just tuned in. So Tanya said, just joined, herniated L4, L5. Pain is worse on the lower side of leg, down underfoot. Any exercises? Just rest. Thanks for advice. We could talk about it a little bit if you want, Tanya. We also talked about it a bunch earlier because we had some similar cases. You can rewind this and it stays on Facebook and the YouTube podcast channel as well. Rick, if you want to mention anything quickly, you can.
Well, gosh, I'm just going to sound like a broken record if I do, I'm sure, because this, especially if it's in one leg, it's likely a side bending problem.
Tanya, this has been a lot of back pain questions today. But yeah, if you just rewind a little bit, you can even rewind it now while watching, or just wait till after. But it's all kind of in the beginning and middle. We talk about it a lot, so
a whole bunch.
All right. Well, I think I'd like to mention Rick's website again. So it's rickolderman.com, where you can find his books, you can find his online programs where you do some what do you call them again? Not classes. What do you call them?
They're just lessons. They're just I've created home programs to help people solve chronic pain, and so depending on which part of your body is hurting, you just get that program, and works pretty darn well for most people because we're fixing systems problems.
And if someone really wants to see Rick personally, you do see people, but obviously that costs more money. He just sees them online. So
yeah, and you can find that link on my website too.
Do you want to answer one more question, or how you doing on time?
I'm doing okay. Yeah.
Okay, we had one just pop up. Rachel says, I seem to have TOS, thoracic outlet syndrome. What exercises would you recommend?
Anything pops out at you, Mike?
Well, I'll be interested to hear your
I
mean, there's certainly...
Do you want to explain what TOS is?
Thoracic outlet syndrome is normally a nerve issue radiating down the arm. It can be caused by different issues. I'm assuming you're probably going to look at shoulder blade dysfunction in that.
Absolutely. Yeah.
There's some PTs get into nerve glides and stuff, which can help some people, but oftentimes it's coming somewhere kind of in your neck or shoulder blade region because a lot of those muscles connect to each other.
Yeah. Again, thoracic outlet syndrome. So the nerves exit your neck to form a brachial plexus that then goes down your arm. And thoracic outlet just means this is the thoracic outlet. And so syndrome just means it's a cluster of symptoms that are happening and no one's really sure why. But usually they involve coldness in the hand. So there's a blood vessel occlusion of some sort. And then there's also numbness or tingling in the hand as well. And does she say whether it's one or both sides, Mike?
Rachel, if you're still watching, just let us know if it's one side or both sides. Yeah, typically people that are listening, you can also have like pain radiating as well with this, or just weakness sometimes as well, and numbness. It kind of depends upon the issue and the person, but
yeah. So most medical practitioners will say, oh, well, you've got a problem with your spine. All right. Well, it's true that the nerves are exiting from the spine and therefore there must be a problem there. But we have to keep asking ourselves, why are you having a problem with the spine? The most common problem that's occurring with the spine is actually coming from the shoulder blade, because there are large muscles attaching from the shoulder blade into the spine and the base of the head. And if the shoulder blade isn't sitting or resting correctly, it will transmit force into the cervical spine through usually the levator scapula, which starts here at the corner of the shoulder blade. And a lot of people with thoracic outlet syndrome, neck pain, and headaches all have pain right here, and it usually radiates up into their neck like that. But it's because of the levator scapula is working too hard. Why is it working too hard? Well, the name says it. It's a elevator of the scapula. And so the scapula must be sitting too low, which is then causing it to work too hard. And so this is usually what I find at the root of a lot of thoracic outlet syndrome that I've seen in the past, is that scapular depression, which is where the scapula is sitting too low, is a cause. So one of the things that we can do to, and there's many reasons why the scapular depression is happening. I don't go into all of that, but an exercise to help at least temporarily correct the scapular depression is to get on your hands and knees and then rock back on your heels like in a child pose position. And most people will feel a fairly significant stretch in their rib cage and shoulder muscles, and which is these scapular depressor muscles stretching out. And then after that stretch, you get up and your scapula is slightly resting in a better position. You should feel an almost immediate improvement in your symptoms. So this is what I would try for her, is to, what I have most people do is this retest idea. So you have thoracic outlet syndrome, rotate your head one way and the other, and notice whether they become more aggravated with head rotation or looking up or looking down, and really dial in on those ranges of motion and the amount of irritation you feel. Then you'll do a couple sets of these stretches, these child pose stretches, to stretch out the scapular depressors. And then you get back up and you do that head testing again by turning the head and see if it feels better. If it does, then scapular depression is likely a large cause of your pain. And so that's an exercise that will at least temporarily fix the scapular depressors.
It's important. Well, she just made a couple comments. She said it's her left side mostly, but also a little bit in her right. And she said it's probably because she sleeps on her left side, but to keep her shoulder dropped down and slightly behind to keep the tingling at bay on her left side.
Yeah, so if it's left-sided more than right side, I'm guessing a side bending problem. So to see whether this is linked to an older problem lower down in your body, take off your shirt and have someone take a picture of your back and see if you have a larger crease on the same side of your thoracic outlet syndrome. If you do, then likely this indicates a side bending problem, which means the rib cage is positioned incorrectly, which means that the shoulder blade is then in position correctly, and it's all playing out at your neck. And so fixing the side bending problem will be likely one of the big things that you would do to fix the thoracic outlet syndrome. So if you have a larger crease on the same side as the thoracic outlet syndrome, or you notice that your pelvis seems to be higher, then this is likely why you're having that. And this is what you ultimately need to solve this from a long-term perspective.
When you're sitting too, try keeping your elbows supported or higher or more elevated too. You can see if I had this one way down like this, my other shoulder's up, this is going to be putting more stress on that area that's bothering you. So that can help just seated. And make sure you're in good position too, because some people get too head forward like this, which is going to cause a lot of problems as well. So just being aware of your posture, I would say it's a big thing. So, okay, we're already over our hour. We ran a little long, but I'm glad we had a bunch of questions. People want to tune in again. Rick and I usually go live once a month. We kind of notify everyone the week before. So if you have any questions, please save them and comment ahead of time if you want. Otherwise, you can certainly join us live. And thank you, everyone, for joining us. And thank you, Rick.
My pleasure, Mike. Thanks for having me.